All right. So again, good afternoon, everyone, and happy Lupus Awareness Month. I'm delighted to welcome you to today's webinar, Lupus and Bone Health, Understanding the Connection, presented in celebration of Lupus Awareness Month. My name is Priscilla Galvache, and I'm the director of the Department of Social Work Programs here at the Hospital for Special Surgery. And at HSS, the Department of Social Work Programs offers the most support and education programs for people living with lupus in the country. All of our programs are free and are available in English, Spanish, and Chinese. And for more information about these special programs, please click the link provided in the chat box. Today, I'm joined by my esteemed colleague, Allison Paisner, who's the manager of the Lupus and APS Center of Excellence here at HSS. Thank you for waving, Allison. Allison will be facilitating the question and answer portion of the webinar following today's presentation. Before we begin, just some housekeeping notes. Participants are going to be muted during the presentation, but please use the chat box to submit questions at any time. And finally, just a plug for our program evaluation. We truly value your feedback. So at the end of today's session, we're going to ask you to take a few moments to complete our brief evaluation survey, and the link will also be posted in the chat box. And now it's my pleasure to introduce our speaker this afternoon, Dr. Jessica Rachel Starr, who's an endocrinologist with a particular interest in women's reproductive health, bone health, and menopause. She is an attending physician at HSS and is board certified in both endocrinology and internal medicine. And Dr. Starr received her undergraduate degree from Cornell University in Ithaca, New York, and her medical degree from the Albert Einstein College of Medicine of Yeshiva University. And she completed a residency in internal medicine at New York Presbyterian Hospital, Weill Cornell Medical Center. So please join me in giving a warm welcome to Dr. Starr. Welcome, Dr. Starr.
Thank you so much for having me. Today, I will talk a little bit about bone health in general, but then also as it pertains to patients living with lupus and their family members. Thank you so much again for having me, and I'd be happy to take your questions at the end. This is a brief outline of the talk for today, a little bit about what really is osteoporosis, who we should screen for it, what is this bone density test that is giving you these results, and then we'll talk a little bit about calcium, vitamin D, some of the medicines available to treat low bone density, and then we'll comment on fall risk and prevention of falls as well as exercise. So what really is osteoporosis? The way I describe it to people, it's a disease where you lose the natural honeycomb architecture of the skeleton. So as you can see in these photos, our bone looks like a honeycomb. It has these natural pores. Osteoporosis, the disease of porous bone. And the larger the holes are in your bone, the more likely it is that if you drop that bone, it could fracture. So osteoporosis, very prevalent disease. 54 million Americans have osteoporosis. We think every 1 in 2 women have it, and that is especially magnified in people with other predisposing factors that we'll get into in this talk. And why do we screen for osteoporosis? Why do these bone density tests? So we know that a lot of osteoporosis is preventable. We think at least half of all hip fractures could be preventable. And we also know that fracture begets fracture, as we say. So having a fracture, especially in that next year, dramatically increases the risk of breaking another bone. So who should we test? It's interesting because a lot of this depends on what guidelines you look at. So there are some more conservative guidelines like the United States Preventive Service Task Force. They feel like you should screen women really starting at age 65 and anyone below 65 who has a fracture risk as high as an average 65-year-old without fractures. The National Osteoporosis Foundation, obviously, they're going to be more aggressive with what they recommend. And so they recommend women 65 and older, as well as men 65 and older. But they also extend recommendations to people who have broken bones past the age of 50 or people who are potentially predisposed to have low bone density from other diseases, such as lupus, such as steroid use, people with underlying eating disorders, people who don't get their period. So osteoporosis, who can have it? And I think the previous slide gets into this concept that osteoporosis you can get sort of from both ends of the equation. You can get osteoporosis from having a low peak bone mass. If you are on steroids as a young person because of lupus or for other inflammatory causes, you might not achieve a very solid peak bone mass. And so you might be sort of starting out from a lower point than your peers. Some of this is determined by your genetics, and some of it is determined by, I say lifestyle, but I really mean more these things that can happen to you during your life, whether it's steroid exposure, missing your period, someone who's not very mobile, not super athletic, doesn't really engage in aerobic activity in their bone forming years. And then also you can have osteoporosis due to bone loss. So women specifically lose bone around the time of menopause. Men lose bone as well, but it's not as a dramatic loss as what you see with women. The average woman in the US goes through menopause around 52 years of age, and starting a few years before that through a few years after that, women can lose 10 to 20% of their peak bone mass. And then there are people who have osteoporosis for both reasons. One, they don't build a robust peak bone mass, or they lose an excessive amount of bone with that menopause transition. So, how can you measure someone's bones? That's this bone density test, which is known in our abbreviations as DXA DEXA, which stands for dual energy X-ray absorptiometry. And basically, the reason it's dual energy is because they're using two different X-ray beams to distinguish between bone and soft tissue. Fortunately, this test is very safe. It has very, very little radiation exposure, less than a chest X-ray. And it can measure certain things, it can't measure other things, which is important. So it can tell us a little bit about the density of the bone and the size, but it's not able to tell us about bone quality, bone strength, the mineralization of bone, or the quality of the collagen. So a lot of times I'll see patients where the bone density doesn't look so bad. It might not be such an impressive score on the bone density, and yet the patient is sitting in front of me talking about 5 different low trauma fractures. This is where I would write in my note and explain to the patient the bone density is not commensurate with the bone quality. So in some people, it doesn't add up exactly, and that's why it's very important to look at the whole patient and not just the test. So the bone density definitely can tell us, do you have osteoporosis or do you have osteopenia, or what we call low bone mass? And it does correlate with fractures in clinical trials. So this is the gold standard test, even though I am telling you from the previous slide, it doesn't answer all of the questions. So the scores are graded in these T scores, which are comparing you to a healthy 30-year-old woman, if you're a woman taking the test. If you're a man taking the test, it's comparing you to a healthy 20-year-old man. And it's basically asking how many standard deviations away are you from that healthy normal. So the normal score on this test would be if you score within a standard deviation of the healthy 30-year-old standard as a woman, let's say. Low bone mass or osteopenia would be if you score a standard deviation below a healthy 30-year-old woman. And if you score 2.5 or more standard deviations below a healthy 30-year-old woman, then we call you osteoporosis. There's also this term severe osteoporosis, which means you score osteoporosis based on T scores, so you're minus 2.5 or more negative, and on top of that, you have a low trauma fracture. These T-scores are important because they allow for standardization between instruments. So if you do a bone density test with us at the hospital for special surgery, and then you go next door a few years later or earlier and you do one at Cornell, our machine is Hologic. Cornell has something called GE Lunar. These are just the manufacturers of the machines, but they measure bone density differently. And so it's very important to know that there's a way you can standardize, and that's why you have these T-scores. Now, in some patients, you might not use T-scores, you might use Z-scores, and this gets very confusing, but basically, if you're a premenopausal woman, you're, let's say, below the age of 52, you still have your period, then the T-score is inappropriate. Then we use the Z-score, and Z-scores compare you to age match control. So if you're 26 and you do a bone density test, and you get your period, you should be compared to another 26-year-old. Also, for men below the age of 50, we should be comparing them to age match peers and children as well. And so how you interpret the test is also confusing because sometimes you get these reports and they give you diagnoses based on sites, like the spine is normal, the hip is osteopenia, the wrist is osteoporosis. What does that mean? So you really look at all the sites and you pick the lowest score. So for example, this is a bone density report I'm showing you here, where you have the raw number values for the bone mineral density. That's the grams per centimeter squared. And then you have T scores and Z scores. So if this is a 55-year-old woman with lupus, you want to take the T-score because we're assuming she's postmenopausal, and you take the lowest site, which in her is the right femoral neck. That's the inner part of the right hip. And you would call this patient osteoporosis. That would be the diagnosis on the bone density test because we're taking the T-score at the lowest site. And like we were saying before, the bone density test, even though I'm saying it's the gold standard, it is imperfect. And the reason that we know that is because when you're trying to correlate the DEXA scores with the fractures, it doesn't always add up. So when you look at women with hip fracture, only about half of them actually score osteoporosis. The rest score osteopenia. And so that gets to this idea that the bone density is not telling us about bone marker architecture and bone strength. In fact, it's a living tissue. It's constantly remodeling, and the test it can't necessarily tell us everything about the bone. And so that's why it's important not just what the bone density test shows, but what the patient in front of you shows and what they're doing. And osteoporosis can be defined based on the bone density, but it can also be defined by a fragility fracture. So if somebody falls from standing height and shatters their femur bone, that's the largest bone in our body, it should not break from minimal trauma. You would call that patient clinically osteoporosis. You could do the bone density test just to have the values and know what they show, but clinically, that patient meets criteria for treatment. We also have this other algorithm that sometimes you'll see on the bottom of the bone density test. It's called FRAX. It's a fracture risk assessment tool. FRAX is really used in the osteopenic patients. Like I said in the previous slide, only half of all women with hip fracture have osteoporosis. So how do you determine if someone has osteopenia? Should we treat them with bone medicine or not? That's where this FRAX tool is actually very important. It estimates fracture risk based on risk factors in people with osteopenia. And if your risk for a major osteoporotic fracture is over 20%, or your risk for hip fracture is over 3% in the next decade, we think that the benefit risk ratio is such that you should offer those patients treatment. And some of the questions we ask for that FRAX algorithm, you actually fill out on a questionnaire before you do the bone density test. It will ask you if either of your parents broke their hip, if you drink alcohol, if you smoke, if you've used high doses of steroids for prolonged periods of time. And all of these questions sort of come together, plus the score on the bone density test in giving someone a risk of fracture. Now we'll shift focus a little bit and talk more about prevention. What can we be doing right now in our lives to prevent having a not good result on the bone density test and to prevent fracture? And calcium. Calcium is actually huge. Calcium is probably the only supplement that has been clinically proven to improve bone density at both the spine and the hip. The recommended intake is about 1,000 milligrams a day for women below the age of 50 and men below the age of 70. Once women go through menopause and men age past 70 years, we recommend that intake increase to at least 1,200 milligrams a day. Vitamin D, it's interesting. Vitamin D actually depends a lot on where you live and how much sun exposure you get because there is not a lot of vitamin D in the food supply. It's often something we get through supplements. For those below the age of 50, you could have anywhere between 400 and 800 international units. You need a little bit more, maybe closer to 1,000 for those over age 50. But I would say, honestly, for those of us here in the Northeast, most people probably do need about 1,000 international units a day, also known as 25 micrograms, to keep their levels over 30. The goal is you want to keep the level over 30 because that's an optimal amount so that your body can absorb the calcium you're eating. We absorb calcium from our intestines, but if we're vitamin D deficient, that absorption becomes imperfect. And in terms of calcium, so calcium is very difficult. We think that a lot of foods are very high in calcium. Patients will always tell me, oh, I'm eating broccoli. But the truth is, there's actually very little calcium in most of our foods. There is some evidence that high doses of calcium supplements are harmful. And so I think it's hard for patients because you'll hear from some doctors, don't take any calcium. It's bad. It's going to clog up your arteries. And other doctors will say, no, calcium is great. Have it. And so I think really here balance is key. I think in an ideal world, people would get all of the calcium from their food supply. But unless people are drinking multiple glasses of milk a day, it's honestly very difficult to do that. So I usually will tell my patients, do your best, have calcium throughout the day from a variety of foods. And at the end of the day, you add a supplement to make up the difference. So if someone can consume, let's say, 600 milligrams of calcium throughout the day from having a yogurt, sweet potato, chia seeds, bok choy, some of these high calcium foods, and then at the end of the day, you take a supplement to make up the difference. I think that that's a nice balance where you're not increasing the cardiovascular risk of using these supplements, but you're optimizing your calcium intake to build strong bones. This is an example of milligrams of calcium in different foods. There are some naturally occurring foods for calcium, and then there's a whole list of fortified foods where the food industry has added calcium to foods. So there's calcium fortified orange juice, there's almond milk, pea milk, soy milk, all of these milk alternatives that also add calcium. Certain brands of tofu are fortified with calcium, oatmeals and cereals. And then there are naturally occurring foods, mostly dairy products, or decent sources of calcium. A lot of people don't tolerate dairy, so I have this other list here on the right, which includes broccoli, oranges, figs, kale, salmon, sardines, collard greens. So there definitely are options out there. And then I also just wanted to touch on reading the labels because I think that sometimes this is very confusing for people. It's usually not written on a label as how many milligrams of calcium, it's written as a percent, but you don't know what the percent is unless you know what the total number is that you're taking the percent of. So whenever you read a label with percent, they're assuming the goal calcium intake is 1,000 milligrams a day. But remember, if you're a postmenopausal woman, you actually need 1,200 milligrams of calcium a day. So when they say 30% calcium in this Chobani yogurt, that means that one serving has 300 milligrams of calcium. And also, we know not all calcium is absorbed equally. So, humans in general are not great creatures at absorbing calcium. We think a human being can absorb about 5 to maybe 600 milligrams at any one time. So, if you, let's say, have a glass of milk and then on top of that, you have yogurt and you sit down and have kale, it's so much calcium that you're overwhelming the intestinal ability to absorb it, and you'll end up excreting some of that out in the urine. And that's similar with the calcium supplements. If you want to take your calcium supplement with breakfast when you're having a bowl of cereal with milk, that might not make the most sense because it might overwhelm the body's ability to take that all up at one time. So I recommend spacing the foods out throughout the day and trying to take the supplements at a time of day when you're not having calcium-rich foods. And then, in terms of the different types of calcium, so many options when you go to the health food store or Amazon to pick these things up. Calcium carbonate and calcium citrate, I would say, are the two main forms. Calcium carbonate is what you find in Tums or those chocolate chews like Adora and Viactive. Calcium carbonate needs acid in your stomach to activate. So, for patients taking proton pump inhibitors like Nexium, Prilosec, this might not be the most absorbable form. And in general, even if you're not taking those antacids, you should probably take anything that's calcium carbonate like Tums with food. Versus calcium citrate, this is better absorbed. You can take it any time of day, and it's maybe a better option for people who don't want to be restricted with when they take the pills or for people using proton pump inhibitors. Vitamin D. So, vitamin D by itself has not necessarily been shown to change fracture risk or improve bone density, but we know it's very important for how the intestines absorb calcium. And there's a lot of research that suggests that vitamin D could have a lot of extraskeletal effects, like could it help with insulin resistance, might decrease risk for colon cancer, it might improve our immunity. And then the optimal dose, I think the reason it's debatable, it really depends on sunlight exposure. And if you live near the equator and you get some sun exposure, you probably could get away with less vitamin D than if you live here in the New York, New Jersey, Connecticut area. The National Osteoporosis Foundation recommends at least 800 international units to 1,000 international units daily to get this goal level over 30. What about other supplements? There's so much out there. There's so much on the internet and, who thinks what. But honestly, it's really all about the calcium and the vitamin D. This table goes over all of the other options and why I don't recommend it. And I would also say most people in our division at HSS probably don't recommend it. So magnesium, there's this thought in science, and it's true that it stimulates the release of parathyroid hormone, which controls calcium metabolism. But calcium is really I'm sorry, magnesium is not really recommended because it's in everything. It's in legumes, it's in nuts, it's in vegetables, cereals, and when people overdose on magnesium, it causes diarrhea, and that diarrhea actually causes magnesium deficiency. So I really only recommend magnesium in people who are feeling very constipated from their calcium supplements. But outside of that, it's not really going to change bone health. Vitamin C. So this is interesting. We do think it helps osteoblasts, which are the cells that build bone. It's very commonly found in different vegetables, oranges classically, but the truth is it's pretty unlikely to be vitamin C deficient. And there's no randomized controlled trial that has ever suggested that it makes a big difference in terms of bone. Vitamin K too. So there's a lot of data, not really data, I would say. There's a lot of talk out there about vitamin K and how important it is for how you absorb calcium. We think it supports osteocalcin, which is one of the important proteins and how we build our bones. However, vitamin K is fat soluble, and most people are not deficient in it. There's really not a great study that suggests that it makes a huge difference in terms of bone density. So for that reason, we don't recommend it. Collagen, this is kind of all the rage these days. Bone is made of a type of collagen we call type 1 collagen. However, there's no randomized clinical trial that suggests that consuming collagen is going to make a difference in terms of the collagen that makes up our bones. Zinc, people are very into zinc, especially since the COVID pandemic, because we think it helps with immunity. It also promotes osteoblasts, which are the bone building cells. However, again, it's something very hard to measure. We don't think the average person is deficient in zinc, and there's not a lot of great scientific data to support its use. Strontium. So many years ago, this was actually recommended by the medical community for its bone effects. It's what we call a weak anti-resorptive, so it tells the body not to break down bone. However, what we think it's doing is that it's actually competing for entry into the bone matrix known as hydroxyapatite. It competes with calcium, but it has a higher atomic weight. So if you put something heavier into the bones and then you do a bone density test, we worry that strontium is just falsifying the numbers on the bone density test, and it's leading to an overestimate of the bone density. Additionally, there are different formulations of strontium, and one of the formulations was banned in Europe because it was associated with an increased risk for heart attacks and just general clotting. This is a little overview of the many options available for osteoporosis over time. And as you'll see in the last, let's say 20 years or so, we have a lot of new agents on the market. From hormone replacement therapy using calcitonin, which is not really done anymore, to the oral bisphosphonates like Fosamax, and Actonel, and Boniva. We now have medicine that builds bone directly, teriparatide known as Forteo, or baloparatide known as Tymlos. We have Prolia and our newest bone building drug, romosozumab or Evenity. So a little bit about bone formation, bone resorption. The anti-resorptive agents, those are medicines like the bisphosphonates, Fosamax, and also Prolia. These decrease both bone formation, the osteoblasts, and bone formation, the osteoclast. And we know that anabolic agents, the medicines that build bone, these actually increase both bone formation and bone resorption. So here really balance is key. We know that the anti-resorptive agents improve bone mineral density and decrease fracture risk, and we think it's because of this reduced activity of osteoclasts. These are the cells that break down bone, and this leads to prevention of bone loss. Additionally, these medicines improve bone microarchitecture because they decrease the perforations or the little holes in the bone, and they promote bone mineralization, like the incorporation of calcium into the bone. And these are medicines like you've probably heard of Fosamax or Actonel, denosumab, also known as Prolia. And then anabolic agents, these are the bone building drugs. These build bone directly and also decrease fracture risk. They work to increase the osteoblast activity, which is promoting bone growth. We know that they improve the microarchitecture of the bone. They increase what we call trabecular bone, which is the main bone that builds our spine. They also promote bone mineralization. I would say the first and kind of most famous of these medicines is Forteo, and Tymlos is, you could think of as a cousin of Forteo. These are daily injectable bone building drugs. And the newest of these medicines, Evenity, is a once a month bone building drug. Now, a little bit about fall risk and exercise. So, how do you know if you're a fall risk? You could actually potentially even do this at home. It's a test called TUG. Basically, you sit in a chair and you stand up without using your hands to support yourself, and you walk about 10 feet, turn around, walk back, and sit down. If it takes longer than 12 seconds to walk these 10 feet, that actually shows already that the patient is at an increased risk for falls. And we know that fall prevention strategies are key to reduce risk of fracture, since most people fracture because they fall down. I think physical therapy is great, even coming for one session. You can come to HSS at any of our locations, and you could work with a physical therapist specifically on balance, on posture, strength training. I think this is all very, very helpful to reduce fall risk. Additionally, we know that patients are at risk for what we call sarcopenia, which is muscle loss. It's sort of a natural effect of aging, but you could argue it might be more common in people with underlying autoimmune disease. And we know that this sarcopenia is associated with frailty and fractures. Exercise itself is very helpful. There are studies suggesting that just exercise decreases risk of hip fracture by as much as 6%. And that's just for 3 hours per week of increased exercise. In conclusion, we know that osteoporosis is a very prevalent condition. It has a large cost to society. We know that bone density testing is an easy to perform screening test and very little downside to that test. We should do bone density testing in all women age 65 or older, men past the age of 70, and anyone who has a fracture past the age of 50, and anyone where we're concerned about a secondary cause for osteoporosis, like a lupus diagnosis, steroid use, history of missing periods in the menstruating years. People at risk for osteoporosis and people who have osteoporosis should consume about 1,000 to 1,200 milligrams of calcium a day and try to keep their vitamin D levels at 30 or higher. And engaging in regular weight bearing exercise, very important for anyone with osteoporosis or at risk for osteoporosis. And I would say using medications to decrease fracture risk as needed is very important. So if you have a bone density test and the result is not a normal result, osteopenia, osteoporosis, I think it's very important to talk to a medical doctor, whether it be an OBGYN, a rheumatologist, one of us from endocrine, to figure out what would be the best next steps and do you qualify for medications. I wanted to leave time to answer questions because I'm sure that there are a lot of questions on this topic. So I will open the floor to any questions that I can answer for people.
Thank you, Dr. Starr, for that excellent presentation and for providing valuable information on managing bone health. At this time, we're going to be transitioning over to the question and answer portion of the program. And just a friendly reminder, please use the chat box feature just to submit your questions for Dr. Starr. So I'll be starting with some of the additional questions submitted during registration, and we're also monitoring the chat for your live questions. So to help us cover as many questions as possible, the submitted questions have been grouped by theme. While we may not be able to address every question during the session, we're going to be focusing on the most relevant topics and aim to provide useful takeaways. So the first question we have that's been touched upon a few times is, can bone loss be reversed through diet, exercise, or other non-pharmacological means?
I think that's a great question. I think to some extent, yes. I think that if somebody has a very calcium deficient diet and they're very sedentary, depending on where in life you pick up this diagnosis, to some extent it is reversible. I think that it's something a patient actually told me this once, and I thought it was so smart. She said that osteoporosis is a childhood disease that we diagnose in old age. And I thought, you know what, that's so smart. And that's because women build bone until the age of 30. So those are really the key years. If you are not someone who's actively exercising, who's not really paying attention to what has calcium in the diet, and you put those pieces together before you turn 30, I think that's the absolute best time to build bone and get to a really solid peak bone mass. Now, if you're postmenopausal, you don't have estrogen, how can you reverse bone loss without taking one of these medications? I think, for osteopenia, definitely continuing a calcium-rich diet, doing really solid strength training, it makes a big difference. But I would also say it can only go so far. Once someone has advanced osteoporosis, I would say T scores -3 and below, that's a degree of bone loss. I think it would be very hard to reverse with just the diet and lifestyle piece. With that said, the diet and lifestyle piece are still very important because our medicines are not going to work as well if the patients don't have the calcium, if they're not doing the exercises. What I always tell people is that Fosamax is not calcium. Our bones are not built from Fosamax, our bones are built from calcium. So if you don't put the raw materials into your body, it almost doesn't matter which bone medicine you pick. It's not going to be able to work to its full potential.
Thank you, Dr. Starr, for that very robust answer. You touched upon this during your presentation, but this was a question asked by many. Which nutrients, vitamins, or collagen are most important for managing osteoporosis risk?
So I would say it's calcium, calcium, and more calcium, maybe with a little bit of vitamin D. I think the issue with some of these other nutrients, it's not that they're not good or they're not important. It's just they're not things that the average person is deficient in. If you're a special case, you have some kind of bowel issue, you don't absorb things, you've had bariatric surgery, for example, all of those are special cases. And this would definitely not pertain to those patients. But if you are an average everyday person, most people are not going to be deficient in things like copper and boron and magnesium. The issue really is that we only absorb calcium from a small part of the small intestine. And so if you're not having calcium throughout the day from different types of foods, you're going to be deficient in calcium. And that's why I say that. And our bone at the end of the day is built from a crystal known as calcium hydroxyapatite. So it's really all about the calcium piece. And then the vitamin D is secondary because we know that if your vitamin D is low, then you can't absorb the calcium that you're eating throughout the day.
Thank you, Dr. Starr. Another question, is taking prednisone a factor that should be considered in evaluating bone density tests?
Absolutely. So, in terms of things that can hurt the bones, steroids are very, very high on that list. Steroids basically tell the body not to build bone and they tell the body to break bone down. So, the American College of Rheumatology recommends that if you take 5 milligrams or more of prednisone or an equivalent steroid like hydrocortisone, dexamethasone, if you take that dose for more than 2 weeks, that already by itself is a risk for low bone density. And some people might even empirically, like just automatically give those patients medicines like Fosamax because they know that the long-term use of high-dose steroids can hurt the bones.
Thank you. Another question from registration. What are the risks of taking Prolia? Are there any dangers of stopping it if it's not tolerated well?
Yeah, so that was actually a great, great question. So Prolia came out in the year 2007, and we were very excited about it because people did very well in terms of bone density. It did really, really well at the spine specifically and made people gain incredible bone, really both at the spine and hip. And then about 10 years into Prolia, so let's say 2017, we started noticing that if people abruptly stopped the Prolia, especially people who had been on it for 2 to 3 years or longer, they were at risk of breaking bones in their spine. It actually got a name. It's called a rebound compression fracture. So if you or someone you know is on Prolia for, let's say, 4 to 6 doses, that's 2 to 3 years. Since it's dosed twice a year, you can't abruptly stop it because this risk is we see it. What is the percent? They say it's 1%, but I think it's probably a little bit higher. I've seen several patients like this in my practice. Prolia is probably a medicine that you really, no matter what, rain, shine, pandemic, no pandemic, you have to show up every 6 months and get it, or you need an exit strategy. And the strategy is you have to bridge off to a different medication. And then that second thing you bridge off to, you could potentially eventually stop. But Prolia, the biggest risk of it is that you can't abruptly stop it. There are other risks as well. If you take Prolia and your vitamin D is very low, that could put you at risk for having low calcium. Prolia has been associated as well with skin and soft tissue infections, like maybe your eczema or your psoriasis gets a little bit worse. I would say in the real life use of Prolia, we haven't seen that skin and soft tissue infection risk as much. I would think the biggest risk of it is this discontinuation side effect. With that said, it does have incredible gains at the spine and hips, so there is a role for using it. Because of these risks of losing bone and discontinuation fractures, the Endocrine Society actually a few years ago recommended that Prolia could be someone's final therapy. So you could potentially go on Prolia when you're 75 and say, this is it. This is what I'm going to take for the rest of my life. I know the risks. I'm going to show up every 6 months and get the medication. And there definitely are people out there doing that.
Thank you, Dr. Starr. A question that you touched when you answered the first question, but can you discuss bone loss after menopause? And that will be our last question from registration, and then we'll move on to the chat box questions.
Sure. So menopause is a time of great loss of bone, no matter what age it happens at. And that's because estrogen is very important for keeping our bone turnover low and keeping the body from breaking bone down. So when someone goes through menopause, the bone at the spine is where we lose from first. It's a kind of bone I touched on in my talk called trabecular bone. It's very sensitive to estrogen. So when someone first goes through menopause, even in those perimenopausal years where maybe you're missing periods, people can lose 10 to 20% of their peak bone mass, whatever the best bone is that they've built up to in that menopause transition. So that actually gets a little bit into hormone replacement. Hormones and going on estrogen, for example, around the time of menopause is very effective because it prevents this loss of bone that happens with the menopause transition. And in the right patient who doesn't have an increased risk of clotting, who maybe has a strong family history of osteoporosis, and maybe on top of that is having hot flashes, night sweats, brain fog, some of these menopause symptoms, the hormones could be a very good strategy to prevent the bone loss that you see with menopause or at least minimize it.
Thank you very much. Okay, so we're going to move on to some of the chat box questions. So one of the first questions are there blood tests to measure calcium like there are for vitamin D?
Yes, absolutely. Now, are the blood tests accurate is an interesting question. So, the problem with a blood test to measure calcium is, let's say I do a blood test and my calcium comes back at 9.2. I might think, great, my calcium's normal, everything's fine, I'm having enough cheese. But in fact, if you're not having enough calcium-rich food, calcium is not just important for the bones, it's important for a lot of metabolic processes in the body. Like, for example, how our heart contracts. It's a calcium-dependent process. So if there is not enough calcium in your body to carry out these basic metabolic tasks, your body will just break down the bones, which is our great repository for calcium, so that there is enough calcium for these metabolic tasks. So you can measure calcium in the blood test, but it's not a great measure of your total calcium intake.
Thank you, Dr. Starr. Someone wrote in the chat box that they've been taking high dosages of prednisone for many years for their lupus and kidney transplant, and their bone density tests are normal. Should they be taking another test to find out the quality of their bones?
That's a great question. That's a very good question. There's a whole separate literature on transplant-induced bone loss and transplant-induced osteoporosis. And there's a lot of literature out there looking at kidney transplant and not necessarily the transplant itself, although that's part of it, but the kidney failure that happens before the transplant and how that affects the bones. I mean, it could be that this person who wrote in this question got really lucky in the genetic bone lottery and got a really great set of bones. And even with these potential insults to the skeleton, with the kidneys not working well and the transplant medicines and the high dose steroids, the bones are really good. Or it could be, like I suggested in my talk, that bone density testing is somewhat imperfect, and there are issues potentially with bone quality and bone strength that bone density can't measure. I would say that for someone on high doses of steroids, a very good test to look at, which is available at HSS and also next door at Weill Cornell, it's called trabecular bone score. It's an added technology that's built into the bone density test, and it tells you for the bone density at the spine, what is the quality of that bone. And sometimes people who take high doses of steroids, sometimes people who have diabetes, other disease states, you can see that even though the bone density appears okay, the bone quality might be impacted. And so for someone like this, transplant history, steroid use, I think doing the bone density in a facility that has this ability to tell you the trabecular bone score is very helpful.
Thank you, Dr. Starr. Another question, how come vitamin D sometimes has the side effect of pimples? And this is the second part, is there a type of vitamin D that absorbs better in the body?
That's a great question. I think that a lot of times the whole issue with the supplement industry is that unfortunately it's not regulated. It doesn't count. It is not considered a medication, so it's not under the FDA's control. It's considered somewhere between food and medication. So I would say all vitamins and supplements that you buy, you should look for the USP label on it. USP stands for United States Pharmacopoeia, and they're an organization that try to look over these different supplements to make sure that there aren't other inactive ingredients that could be potentially harmful or could have other side effects. There is this company called Maximum D. They make a once weekly vitamin D that's pretty bioavailable and gets good absorption. We sometimes recommend that for people who, let's say, are gastric bypass patients or for other reasons don't absorb traditional forms of vitamin D well. I would also comment on there's D2 versus D3. D2 is the prescription ergocalciferol. Some people really like that because it's, you could say, easier. It's once a week, it's a prescription. But actually, the D3, the over-the-counter D, is better. It binds to the vitamin D receptor for longer and it improves levels more than the prescription D2.
Thank you. Someone in the chat mentioned that they had kidney stones that were calcium, but were told not to take calcium. So is there calcium that they can take?
That is a great question. So this is definitely a, very individualized case, but a lot of patients who have calcium oxalate kidney stones can't take calcium because the nephrologists or urologists are worried that high doses of supplemental calcium will end up getting excreted by the kidneys. And I think, it's hard to comment without knowing the specific case, but I would say for people with kidney stones, probably dietary calcium is the safest, and focusing on foods that are good sources of calcium that are not going to exacerbate the kidney stones.
Thank you, Dr. Starr. Are there veggie sources of vitamin K2?
That's actually a great question. And I'm not sure if I know the answer, and I don't want to say the wrong thing. I want to say maybe dark green leafy vegetables, but I might not be 100% sure on that.
Thank you. And somebody else on top of that asked if your thoughts on like V8 products.
That's a great question. I mean, in general, I think that those products are pretty good. They have a lot of good nutrients in them. I think I always tell people in terms of, just this epidemic of obesity and diabetes and inflammation that is out there in the world. I always tell people consume whole foods. If you can go to the supermarket and the ingredient list doesn't have, 10 compounds that you don't recognize, that's a good food for you. And I think having the V8 juice, I think isn't definitely an option, but I think go out, buy the tomato, buy the carrot, eat the whole foods.
Diving deeper into that, can the GLP-1 drugs help with diet and weight management with lupus?
That's a great question. So those are very interesting medications in that we see a lot of patients get referred to us in endocrinology from rheumatology or from the lifestyle medicine program at HSS. And what some of us are noticing is that even before the patient loses weight on these GLP-1 agonists like Wegovy or Zepbound, they are seeing anti-inflammatory effects and their arthritic symptoms are getting better, whether it be psoriatic arthritis, rheumatoid arthritis, lupus. And so there's clearly more to these drugs than weight loss that I think we're still discovering as a scientific community. I do believe that they have anti-inflammatory effects and that the joint symptoms can get better in addition to the weight loss. And if you are overweight, you're putting extra stress on the joints, then losing the weight, whether it's through these medications or other means, will definitely help those symptoms as well.
Thank you, Dr. Starr. Someone in the chat was asking what kind of doctor they should see and which tests should they request for chronic hip and joint pain.
That's a great question. I would say Amy, if you have an underlying diagnosis of a rheumatic disease, I would say refer back to your rheumatologist because the question is this related to my lupus or my rheumatoid arthritis, or is it something else? Otherwise, maybe primary care would even be a great place to start to see, are there signs of an inflammatory process? Is it more an osteoarthritic process? Maybe this is someone who could have even just baseline x-rays to see, is there any kind of joint inflammation going on? A primary care doctor might also recommend referral to someone like a rheumatologist or someone like a physiatrist who specializes in the non-operative management of bone and joint problems.
Thank you. Another question is, does having too much calcium or using supplements rather than food affect your heart and or calcium scoring test?
That's a great question. So we don't believe that having calcium in the form of supplements would affect the calcium scoring test or calcification in the walls of the arteries, although there are studies suggesting that really high doses of supplemental calcium, like 2 grams a day, and that area could potentially lead to calcifications. Those calcifications that you're seeing in the coronary artery calcium score are more calcifications from chronic inflammation in your body throughout time. It's not like you took a Tums and now the coronary artery calcium test is positive. Consuming 2 grams a day of supplements is a lot. I don't really find people doing that. I think if you keep your calcium supplements below 1,000 milligrams a day, there is no study out there that has ever shown that that is problematic. So I think that's a safe amount. Also, remember, calcium is not well absorbed. So if you think that you can have 1,000 milligrams of calcium in a pill, that 1,000 milligrams, probably half of it you get absorbed and the other half you urinate out.
Thank you. And can you speak to the comorbidities of osteoarthritis and rheumatoid arthritis and what support someone may need to combat inflammation?
Absolutely. I think depending on the root of the inflammation, there could be a lot of comorbidities. Some of our autoimmune rheumatic diseases could potentially affect other organs. And for example, a disease like rheumatoid arthritis that has systemic inflammatory components of it that could affect other organs. It could affect the bone density. Osteoarthritis, it's more a disease of aging. It's a loss of the protective cartilage between bones that causes them to rub against each other. That has less systemic effects in terms of inflammation. That's more like local inflammation as opposed to rheumatoid arthritis, which is systemic inflammation that can affect other organs.
Thank you. Someone was curious in the chat, where can we get bone density tests?
That is a great question. So bone density testing, I guess one question is like, who would be ordering the test? And then the other one is like, where can you physically go? So it's something that a primary care doctor should be offering to their patients, women who are postmenopausal. Often the gynecologist ends up ordering it because just logistically, a lot of the places that do mammogram testing or imaging places that can also do a bone density test. HSS has a bone density machine, so physically we're a place you can do a bone density test. I would say most major medical centers have the ability to do the test, but a lot of private imaging places do as well. In terms of doctors who feel comfortable ordering the test, I mean, at HSS, our orthopedic surgeons, our physiatrists, a lot of the colleagues we have at HSS are very tuned into this idea of bone density testing. So you might get it ordered by your physiatrist or your orthopedic surgeon. But I would say for mainstream everyday people, probably a primary care type of point person, whether it's the primary care doctor, the gynecologist, those types of physicians.
Thank you, Dr. Starr. Another question. Do all medications used to treat osteoporosis contain estrogen?
That's a great question. So I would say actually very few medicines that we use to treat osteoporosis contain estrogen. Estrogen for hormone replacement can help prevent osteopenia from becoming osteoporosis, but the medicines that we use to treat osteoporosis are usually focusing on either preventing the cells that break down bone from being active, those are anti-resorptives, or they're focusing on telling the cells that build bone to be more active, and those are known as anabolic agents. Those are sort of the two main categories for the medicines to treat osteoporosis.
Next is a DEXA scan for bone density tests, or is it the only way to test?
That's a great question. I would say that from a clinical perspective, what's available today to the general public, bone density testing is the only test that is available to look at the bones. However, you could argue that there are other ways to kind of get at bone quality. If you're having orthopedic surgery, for example, I often will see someone who goes and has orthopedic surgery because they fell and broke a bone. And the surgeon says to them after the fact, I looked at your bones because I was in there fixing them and I saw that they were soft. I saw that they were weak. I saw that they were very porous. And so that could be another way to kind of get at this question of how are my bones? How is my bone quality in the context of an orthopedic surgery? Sometimes people, for one reason or another, have a bone biopsy. Sometimes you can even see it on imaging, like you have a bad cough and someone does a chest x-ray and they see that on that chest x-ray, even though it was being done to look at the lungs, the ribs looked very porous.
Thank you. Next question. Some drugs cause bone loss in the jaw. What drugs do not cause the jaw bone loss?
So I guess I would say a few things about that. One I would say is that this bone loss in the jaw that we worry about, it's a very rare dental complication of our medications known as osteonecrosis, where the jawbone doesn't heal very well if it already has some kind of injury. It's pretty unusual to see in the osteoporosis world. We technically would report this as a rare side effect if it is seen. We see it a lot more when our medicines are used in cancer patients. And that's because if you're on a medicine for bone, and you're using it for osteoporosis, the dose itself and the dosing frequency is much, much less than if you're on the medication to prevent cancer from affecting the bone. With that said, the medicines that build bone directly, the anabolic agents, the Forteo and the Tymlos, those are daily injectable versions of parathyroid hormone. Those have a zero risk of osteonecrosis of the jaw. They're not associated with it at all. But if you look at Fosamax, even though out there on the internet, it might make you might make you think that it's causing a lot of bone loss in the jaw. The truth is the risk of osteonecrosis of the jaw in someone using Fosamax for osteoporosis, it's actually less than 1 in 100,000 people. So very, very, very unlikely.
Well, thank you. Is there any evidence that Fosamax can lead to brittle bones?
So that's interesting too. I think a lot of that comes from, maybe I want to blame the orthopedic surgeons. I'm not sure exactly where it came from, but when these drugs first came out in the late 1990s, we used them very liberally. We put people on these bisphosphonates like Fosamax and Actonal sort of indefinitely because we thought, you know what, it's a good medicine and the more the better. And then about 10 years into these drugs, we realized that you actually can't do that. And that's because of these brittle bones. So around 2009, 2010, we started seeing that if you use the bisphosphonates for prolonged periods of time, you overly suppress bone breakdown, then you can get these brittle bones. And that's where that other scary atypical femur fracture side effect came to light, that people who had been on the bisphosphonates for prolonged periods of time were actually breaking their femur bone, which again shouldn't break. It's the largest bone in our body. So we know that overuse of these medications is not good for bones, but we know that if you use them for short periods of time, like let's say 5 years, and then you take a drug holiday and maybe a couple of years go by, you go back on them, that is safe.
Thank you. And do you consider walking as a weight-bearing exercise?
So technically, yes, you could argue that any exercise where it's your body against the forces of gravity is considered a weight-bearing exercise. So walking can be considered a weight-bearing exercise. With that said, we know that weightlifting and really strength training is better, and the more weight that someone can bear, the better it is for their bones.
Thank you. And would bone scans be needed for all lupus patients?
That's a great question. I don't think I can say that officially. I think it depends on the patient. If it's a lupus patient with mild lupus who has regular periods and has never been on steroids, probably that patient could wait until they're postmenopausal and get a bone density test based on the average screening population recommendations of women at age 65. However, if it's someone who has been on steroids, if it's someone who's had a fracture, if it's someone who has been hospitalized for prolonged periods of time, it might make sense to talk with your rheumatologist about should you do this earlier. Also, family history. Like if your mother and her mother both had hip fractures from osteoporosis, then no, I don't think that patient should wait until they're 65 to do their first bone density test, especially because there are preventive things we can do. If someone is osteopenic right around menopause, maybe that's someone we would talk to about hormone replacement therapy.
Thank you, Dr. Starr. Some of these questions might be a little too specific, but is it too late to take bone meds after age 80?
That's a great question. I would say it's never too late to take bone medications. I get this a lot actually from patients. Like I'll ask about their family history, and the patient is maybe in her 50s or 60s, and she'll start talking about her mother who's 85 and slipped and fell and broke something. And then I'll hear, but she was too old, so we didn't give her any medicine. But as I said in the beginning of my talk, fracture begets fracture. If you fall and break your hip, your chance of having another major devastating fracture in the next 12 months is so high that absolutely I think all of those patients should be treated. And I think also there are gentler medications that we can use for people who are older so they don't have to enter into something like Prolia, let's say, where now they have to get it every 6 months and maybe they have multiple medical problems and their mobility is impaired and they can't physically show up somewhere every 6 months reliably and get the medication. But for people like that, there definitely are other options that we can use.
Thank you very much. Um, so someone who has been tested for calcium and not low, does taking more calcium even help if my tests say I'm not low?
Well, the problem with the tests is the tests are not the most accurate for total body calcium scores. I would say the most accurate test that we could offer, although I'm not encouraging everyone to run out and do it, but if you collect your urine calcium over 24 hours, how much calcium are you excreting? That can give you a sense of your dietary intake. If you're not eating enough calcium, your 24-hour urine calcium might come back low to suggest that. I think really to figure out if you have enough calcium, you can't figure it out from the blood because your body will just use the bone as a buffer and you'll break down bone so that the measured calcium in the blood in most people comes out normal. It's really about looking at your diet and seeing are you able to get 1,000 or 1,200 milligrams of calcium a day from various food sources. And if you feel like you're not getting that amount, then using a supplement to make up the difference.
Thank you. Are there any symptoms of low calcium?
That's a great question. So, calcium and the symptomatology really depends on how fast the calcium drops. If you walk around chronically calcium deficient, you probably won't feel it. But if suddenly your calcium levels get very low, you might feel very bad. People can feel very nauseated, they can feel achy, they can get their hands and their body into almost like a little bit of like a stiff feeling where they can't relax their muscles. And that's something that you see if the calcium drops very quickly. It would be unlikely to see that happen in someone just from one day to the next. So it's sort of hard to know if you're walking around and you're calcium deficient. If you get very calcium deficient, you could, plus maybe some low vitamin D, you could actually get pain in your bones. Like you could have pain in your long bones and your legs and your arms. But again, that's less likely.
Thank you. We have time for one more question. Someone asks, is medication a good option for lupus patients on steroids if they are diagnosed with osteopenia and not osteoporosis yet, or would diet and exercise be enough to try first?
It's a great question. I think it really depends on the doses of the steroids. If someone's taking prednisone 5 milligrams or more for more than 2 weeks, then the data really suggests that medications are helpful in reducing bone loss and fracture risk. But along with that, focusing on calcium and vitamin D is very important because, again, the medicines are not calcium. The medicines are just telling your body either to build bone or not break bone down.
We could do one more. Is there a lot of radiation in these tests?
No, so that's actually very reassuring. So a bone density test has much less radiation than a chest X-ray. If you fly from here to Florida, you will get more radiation just from the solar system than you will doing a bone density test. So it's really not a lot of radiation. You can do a bone density test as often as every 2 years. Sometimes we can even get approval once a year, especially if you're on treatment with medications for your bones.
Thank you. This is a good question. Are vegans and vegetarians more likely to have bone density issues?
That's a great question, actually. I think it depends on who the vegan and vegetarian is and what they're eating. So, meat in general is not a great source of calcium. So, if you're a vegetarian and you have dairy and you have eggs and you have fish, it's probably okay from a calcium perspective. Vegan, obviously, a little harder if you're not going to have eggs, you're not going to have dairy. I think that you could be at higher risk if you're not aware of what foods you can eat. Chia seeds have calcium, tofu is fortified with calcium, oranges have calcium, figs have calcium. So, you can do it if you're vegan. You just have to know what are those foods and seek them out.
Wow, thank you so much for all of you participating in this webinar and for Dr. Starr for sharing her knowledge with us today.